Okay, it looks like everyone has had a chance to grab a lunch, so we can go ahead and get started with our fourth and final speaker, Dr. Fiona Scott Morton from Yale University. I think Fiona is the first speaker I've actually had come. We've done this conference 7 times. You're the first person that I've had come back twice because, she's just that good. In her career, Fiona has served as you'll see in her bio, she's actually served at DOJ in lots of regulatory issues. So she has both the academic experience and the government experience. She's got a whole wide variety of issues that she studied during her career. One of the things I remember most of her is her analyses of the Medicare Part D program and its impact on consumers. What she found is that Medicare Part D did indeed sort of lower the cost of drugs for seniors, but that it increased utilization. But it's sort of more of a complex story than just that, because it also led to some suboptimal choices by consumers, and we've heard a little bit about that earlier this morning, and also increases the price of drugs for which there are no substitutes. And so that's still an area that's in play and needs some additional work. But Fiona also goes beyond healthcare. I've noticed looking at her webpage that she's actually looking at the harms of digital platforms in general for consumers and working with other people trying to find solutions to those particular problems, and how do we actually revise our antitrust laws, which were really built for industries decades ago and don't necessarily have all the protections we need for consumers right now. So with that, a topic, I'm sure you've all heard about this in the news and read some of the newspaper articles, but let's hear about this from a real expert on this issue on surprise medical bills. Welcome, Fiona.
Thanks very much. It's a pleasure to be here. I thought before I would start in on out-of-network billing, we'd have a short aside, since we've been talking today about the value of choice. I would give you some choice in the marketplace for ideas and talk about Medicare for all for 60 seconds. We spend about 19% of GDP on healthcare. Other industrialized countries spend more like 12. So let's just note that Medicare for all is not adding 12% of GDP to our healthcare spending. The whole point of it would be to replace the 20 that we're currently spending with 12, which is less, okay? So, the point here is not, Professor Ho said our country can't afford Medicare for all. Well, if you went from 20% spending down to 12% spending, you can afford it. You're in fact saving money. John and Michael showed us this morning that our private system cannot control costs. I'm increasingly of that view, and you'll see that this paper contributes to that debate also. And so if you can't make it go with the private system, it's entirely predictable that Medicare for all would be your next choice. Like we've tried different ACOs, we've tried the Affordable Care Act, we've tried various things, they don't work, so we're gonna go for Medicare for all. What is the affordability of that? Well, all of us are already paying $25,000 a year for health insurance, and it's just that we don't see it because our employers pay it, but it's part of our wage. So how would this work in terms of paying for it? Well, you tax a few billionaires, and then the rest of us have exactly the same profile we had before. Instead of our employers paying for us, we take that money and we pay to have Medicare with it. And then you have to get some additional money if you want to expand to the uninsured, which is where the billionaires come in. But the point is just that we can afford anything we want. We're the United States. It's just the question of whether we want to. So I just wanted to interject that before I start. Okay. So, out-of-network billing in the United States. This is a project joint with Zach Cooper at Yale and former RA, now student Nate Chiquita. So every year there's a lot of emergency room visits. The key thing that you might not know is that physicians do not necessarily participate in the same insurance network as the hospital in which they practice. So a responsible consumer going to an in-network hospital with her broken leg can be treated by an out-of-network doctor. And then that out-of-network doctor sends a bill. The insurance company may not cover it because it's out-of-network care. Okay? And this does a couple of things. It exposes patients to significant costs, out-of-pocket costs they weren't expecting, and it undercuts the functioning of healthcare markets because these physicians are not competing on the basis of price for your business the way the hospital did to get into the network. They're just surprise billing after the fact. So what we have here is a data from one large national insurer, and I'm going to show you the scale of the problem, what's driving it, and then I'll give you the policy answer. Okay, so we have 130 million emergency department admissions per year in the United States, 10% of healthcare dollars. This is not a trivial issue. Number of people arrive by ambulance. They may not be choosing where they're going. Use of EDs grows faster than population growth. I'm not sure quite why that is. But perhaps because of that growth in ED demand, the challenge of managing and staffing the emergency department, which is a 24/7 thing, has given rise to physician outsourcing firms. A hospital will contract with a management firm that will run the emergency department and make sure there are doctors in there all day, every day. The two dominant firms that are physician staffing companies are MCare and Team Health. MCare used to be public and was taken private largely because of this paper, Zach and I think, and I'll explain that to you in a minute. And then Team Health is also private since 2016. These companies work in many, many states, and they have thousands and thousands of doctors working for them. So Team Health is 18,000. MCare is bigger than Team Health. Okay, there's two kinds of out-of-network billing, and we're only really concerned with one of them. So one kind of out-of-network billing you might encounter would be, it's just hard for physicians to have a contract with every insurer, even the little ones, and so sometimes you're skiing somewhere far away and you have a broken leg, and it just happens that the doctor's not under contract. That's pretty rare. That's not the policy concern that we have here. The policy concern we have is the small but significant number of ED physician firms that purposefully take themselves out of insurance networks in order to be inside the ED and outside the insurance network so that they can charge a high price, okay? Those are on-purpose strategies to be out-of-network billing. So that's the thing we're worried about here. Okay, what's the previous literature look like? We use this data to write a very fast paper to say, look, this is a big problem. It's 22% of visits to the ED. There are two other papers out there. One, I'm happy to say, Texas, based on Texas data, because Texas had a massive problem with this. The three largest insurers in Texas had a lot of their hospitals with 0 in-network emergency department physicians. Okay, so you guys were the first to study this. Subsequently, there are the two papers up there that pointed out that in more representative data sets, it's a big problem. But we didn't know anything about the location, the driving force behind it, what was exactly causing the in-network billing. So that's what this, out-of-network billing rather. So that's what this paper is about. The out-of-network rate here is plotted by geography. Darker colors are more out-of-network billing. The darkest is from 40% up to 100%. So you can see that Texas here is pretty terrible, Alaska, as is a lot of the South. The upper Midwest with all those Swedes and Germans is very good, as usual. Okay, what happens when physicians are out of network? There's a number of things that can flow from that. The physician might get offered the in-network payment by the insurer and take it, and then the patient is going to experience just like they would if it were an in-network experience. The provider could alternatively demand their charge. Okay, this is a made-up number that the doctor puts on a piece of paper. Then the insurance company might pay that, and that might cause the patient to have a higher cost sharing because they might have to pay a percentage, for example, of the bill. So they would bear the higher out-of-pocket cost. It might be that the insurer says, that charge you sent me is too big, I'm going to negotiate it down. and the provider agrees to the lower rate, so then the patient would be exposed again to cost sharing that's more than they would normally have, but perhaps not the full amount that the doctor's looking for. And then the last one is the most dangerous one, which is the insurer doesn't negotiate the charge down. The insurer just pays some amount. And the provider is then free to balance bill the patient for the rest, right? So the in-network rate is $250. The doctor sends a bill for $1,000. The insurance company pays them $350, and then the doctor says, right, well, I got $350 and my bill was $1,000, and so I'm going to go out and send a $650 bill to the patient. Okay? Last option is the insurer says this is an out-of-network charge. Your insurance doesn't cover out-of-network, and we're paying zero, and the whole $1,000 is on you. Okay? So these are all bad outcomes for the patient. Let me point out that physician payments as a percentage of Medicare rates are quite high when it comes to emergency department visits. Okay, so if you think about internists, 158% of Medicare, orthopedists, who people think are well paid, 178% of Medicare. In our data set, the mean in-network payment for the ED physician for a standard visit was 266% of Medicare. And the mean charge, that's the number written on the piece of paper, what we'd like to be paid, was 637% of Medicare. Okay? So these are quite large amounts of money. They're quite large amounts relative to Medicare payments. So if you're thinking about, the poor doctor, should we be giving them more money? You can decide whether 266% of Medicare is too low to be paying the doctor. The potential balance bill in our data set is about $450. So we don't see whether patients ever pay that, but that's the amount of money that we're talking about. And for a typical family, that's quite a large number. Okay, this is just the financial services industry realizing the strategy of MCare. Okay, since MCare is out of network, it refuses to sign in-network agreements with local insurance providers. It can charge exorbitant out-of-network reimbursement rates from its providers and balance bill its patients for the difference. This is a license to print money. Okay, so this is Badger Consultants, LLC, advising people what to invest in. Okay, so this is American healthcare at its best. All right, and this strategy was covered in the newspaper a few times in the 2014, 15, 16 timeframe, but again, in an anecdotal way without data. So what can I tell you about the data? Before we get to the data, let me just make sure we're clear on two incentives. For this to happen, the hospital essentially has to let the doctor into the ED to practice in this way, okay? And the doctor has to want to be in the ED practicing in this way. The insurer is a third party, not really in control of that, but responding to the situation. So the insurer is going to decide whether to put the physicians in network or out of network, and that's going to depend on the price that physician charges. Keep in mind that one of the big problems caused by out-of-network billing is that if the insurer says to the doctor, "You're charging too much," the doctor is able to say, "If you don't pay me, I will just get a job in the hospital anyway, be in the emergency department anyway, and triple the bill I send you. So how about you agree to my overcharge up front, and that will save us all a lot of time." If you were a pediatrician who tried that, I'm going to say to the insurance company, "Pay me a high rate." And if you don't agree, I'm going to bill you anyway. The insurance company would say, "No, you're not, because I'm going to steer my patients away from you. You're an out-of-network provider, and when they're planning a pediatrics visit, they're not going to choose you because they can see you're out-of-network." The problem with the emergency department is the patient can't do that. The patient is going to an in-network hospital, and inside that hospital is the out-of-network physician. So there is nothing the insurance company can do to steer patients away from that doctor. Okay, so that's the problem. And then the insurer's outside option, if the doctor sends a bill for $1 billion, is only to go to court and claim some kind of violation of a state law, such as an overcharge or price gouging kinds of laws that some states have, okay? So it's not a good situation for the insurer. The insurer who gave us this data set was really happy when we discovered all of this stuff and could write it down, because they had felt somewhat powerless in this situation. Let me talk a little bit about the hospital. The hospital has to staff the ED, and the ED is very important as a place that patients enter the hospital, so you really want to have the ED there. We think that the hospital faces some reputational cost when out-of-network billing occurs inside their ED. Okay, it's a very unpleasant experience for people to get this bill after the fact. So the hospital is going to need to be compensated in some way for incurring that reputational loss from having those bad bills. And the hospital's willingness to adopt this strategy, to let MCare come in and run their emergency department, is going to depend on how much they value profits versus how much they value patient welfare. What we see in our data is that MCare really is mostly in for-profit hospitals. It's not in nonprofit hospitals. And we think that's because it's a very lucrative business model, and they're sharing some of that lucrative business model with the hospital in exchange for being allowed in the door. Okay, so now let me show you the data. So again, we have one large insurer. This insurer covers tens of millions of lives per year. The majority of the people in our data set are enrolled in a self-insured product. The employer is self-insuring. We have detailed patient characteristics. We have the provider ID. We have the ability to link to a range of third-party data sets like the hospital, the American Hospital Association list. We have claims from 2011 through 2013. We see when the patient goes to the emergency department, we see all the emergency department codes. We see how much the insurer pays the physician. We see how much the insurer pays the hospital. We don't see any balance billing payments. We don't see if the patient 6 months later pays the doctor an extra $300. We can't track that down. We can tell you what the potential balance bill is, but not if any of it ever got paid. Okay, so we identify the claims that are emergency care. We take on the facility side all these numbers. You see listed the revenue codes for for hospital visits, and then we have the revenue codes for the physician side as well. We leave out very tiny hospitals, only 10 episodes annually. We leave out anything that is messy, looks like it has measurement error or negative prices and all that kind of thing. We Windsorize the top and bottom 1%, so our results are not being driven by one crazy ED visit that cost millions of dollars. Okay. What do we have? We have $28 billion of spending over our 5 years, and you can see that $26 billion is facility spending, $3 billion is physician spending, and nearly everybody is going to an in-network hospital. These are not people who are on vacation and find themselves out of network. They're all going to the hospital they're supposed to be going to. It's just a tiny amount of claims that are at an out-of-network hospital. Okay, and we have millions of episodes each year, about 1.7 or so. So we have plenty of data. Okay. What does it look like? This is probably the most important graph. When we published our first paper, we said that 22% on average of claims are for an in-network emergency department visit are dealt with by an out-of-network doctor. That gives the impression that you arrive at a hospital and you have a 1/5 chance of getting one of these out-of-network bills. That is not what the picture looks like. Most hospitals are clustered here at the almost nothing spot. Those almost nothing spots are what I talked about before. Every so often somebody turns up and the networks don't line up and you have an occasional out-of-network bill. There's hardly any hospital in the middle. The next cluster is up at nearly 100%. These are hospitals where their emergency department doesn't have doctors that are in network practically at all. Okay? So that's a hospital that's got an ED staffing company that has a business model of not being in network. Right? So that's just really important to understand. The right-hand end is a business model. The left-hand end is, I think, natural frictions in the way contracting works in U.S. healthcare. Okay. So we went to find out who these hospitals are. It turns out they're MCare and primarily. There's some team health, which I can talk about at the end if there's time. MCare makes it quite difficult to identify them in insurance claims. And this, you can see why as this story unfolds. They do continue to use the physician's original tax ID and NPIs and so on, but they don't post a list of where they have operations. So what did we do? They have a map on their webpage that shows where they're active, and it turns out the little dots on the webpage map had latitude and longitude underneath them. So we had a clever RA scrape that code and then go find out what hospital was at that lat long. They also have a webpage where they post openings for doctors, and in those posted job openings, they have to say what hospital you're going to be working at. That's obviously of interest to the prospective applicant. So those two sources of information enabled us to identify a hospital as MCare. We have them on the map, and we have the job listing. So that's what it looks like. Okay, and that's what the hiring page looks like. Emergency physician, full-time, Liberty Hospital in Missouri or wherever, Montana, whatever MO is, I forget. Okay. All right, so that's the cross-section. We also have a 5-year time frame, so we can search for hospitals where MCare enters or exits in terms of running that emergency department. So we searched for press releases from MCare announcing that they went into a hospital or they exited a hospital. And we called all the hospitals in our data set, and we asked them about the entry dates of MCare, or whether they had a staffing company come in and what the date was. All right, so what do we end up with? We end up with entries, 36 hospital entries, 3 hospital exits, spread over time in the following way. So that's a decent amount of variation and experimentation, and I'll show you what happens when MCare enters a hospital in a minute. So the MCare hospitals, the MCare entry hospitals look remarkably similar. There's no really reason to dwell on this page. Let me show you instead, oh shoot, sorry, wrong order. I'm going to show you something else before we go to what happens when they enter. So as I said, there's 2 ways to think about MCare. There's where they operate, and then there's in our time frame where they enter. If we take first where they operate, we can just ask, does that look different than where they're not operating? Okay, and that's what this first analysis is, and then we'll move on to the what happens when they enter. So we take some variables about the neighborhood and the hospital, and we ask, do these neighborhoods and hospitals look different, the ones where MCare is inside the hospital, than neighborhoods and hospitals where they're not? So we have census data information, American Hospital Association data information, concentration measures, and then this emergency department management dummy. Okay, so you can look and see that the result, if you wanted to predict what causes out-of-network billing, the MCare indicator is the thing that you care about. Okay, up here, the only thing that's really huge. That's if you have MCare in your hospital, that's going to establish, that's going to cause you to have way more out-of-network billing. The other things on this list that are hard to read mostly don't do very much by way of moving around out-of-network billing. Teaching hospitals have less, okay, nonprofits have less, residency training approval have less, so these are all kind of very nonprofit hospitals, have less out-of-network billing. There's a little bit more in neighborhoods that have more inequality and in more urban neighborhoods. Okay, so what happens when we go to entry? So when we go to entry, our specification is very straightforward. It's, let's think about network billing, the prevalence, or the price that the insurer pays, or the price that the consumer pays, as a function of all the normal stuff that we would normally think about, plus this entry or exit of MCare. Okay? And we're mostly, the controls that we're using here are mostly just fixed effects and dummies. So you're holding a hospital constant, they run along having a certain amount of out-of-network billing, and then MCare arrives, and the question is, what happens, right? Nothing, up or down. Okay, so what you can see is that we have a little bit of a problem, because if you have high out-of-network billing, like 99% out-of-network billing, when you have MCare come along to run your emergency department, okay, it really can't go up, right? You could have an effective MCare causing it to go down, but you can't have effective MCare going up. So here's what we do is we divide our hospitals into two groups, the ones on the right and the ones on the left, okay? And we're going to run two separate regressions, because you're going to see that what MCare is going to do is for the hospitals on the left, it's going to shift them way over and they're going to start out-of-network billing, but the hospitals on the right are already doing that. They can't move. So we don't want to put them in a regression where they're going to give us a zero effect, but not for a reason that we're interested in. So let me show you what that looks like. Hospitals with out-of-network prevalence below 90% prior to entry are in column 1. So if you're below 90% and MCare arrives, the prevalence of out-of-network billing goes up by 82%. Okay, 82 percentage points. You go from nothing to, 0.85. Okay, if you had hospitals with out-of-network billing prevalence above 90% already, and MCare enters, nothing happens to your out-of-network billing proportion, but that's because it was already at 0.95 or whatever anyway. When MCare exits, out-of-network billing prevalence drops by 76%. Okay, so it's a very simple story. They come in, all billing becomes out-of-network, they leave, billing goes back to being in-network again. Okay, and you can see that in the pictures. So this is our various hospitals in the months leading up to the point where MCare comes in and runs the ED. And then you can see afterwards, the red line is the mean of the data, and then MCare exit on the right-hand side, same thing. The gray shadowed areas are our area of uncertainty. We don't know always exactly the date when MCare took over. Sometimes we know it inside a month or a quarter, and so the gray is just where we're a little less sure of whether MCare is in charge or not. Okay, so now let's look at some other outcomes. It's not just the prevalence of the out-of-network bill, but where does the money go? If you send that out-of-network bill, somebody could just throw it in the trash and give you the in-network payment. So does that happen? No, that does not happen. Let's look at how MCare entry affects the physician charge, the total payment, and the insurance payment and the patient's payment. So what we can see is that the charge filed by the physician goes up by about $500. They don't collect all of that. What the physician actually collects is $438 more. The insurer is paying the bulk of that. Our insurer is relatively generous, so our insurer is paying $392 out of the $438 additional dollars. The patient is paying another $50. So this is real money being distributed to the doctor or MCare via this out-of-network billing mechanism. Their charge is going up, their payments are going up, the insurer is paying more, the patient's paying more. As I said, the potential balance bill goes up, $460, but we can't see how much of that it ends up being paid or not. Now, columns 6 and 7 are important, and they're important because they're another kind of category of problem for MCare. When MCare enters a hospital, the fraction of admits to the ED that are coded as having the highest severity goes up by 11%. So you might wonder, why are all the really sick people showing up all of a sudden compared to yesterday? And I will leave you to draw your own conclusions about that, because I don't want to say anything too terrible in public. Okay, but the reason to call your attention to column 7 is that we're not seeing a large increase in the number of patients treated. It's not like there's some miraculous efficiency happening at this emergency department that's, causing throughput to get higher or something like that. Okay, let's keep going with what else we can learn here. We can see that the RVUs billed by physicians go up by 21%, and that the physician charges in various of these CPT codes are also rising by significant amounts. I mean, that's, for those of you in the audience with a medical background, maybe you'll care more or less about these, but the previous chart essentially gave one summary number. Okay, so this is the physician charge, same kind of story. This is negotiated rates, same kind of story. Physician coding. The physician coding, as I said, is problematic because it's not clear that that's based on a real change. And if you have the same patients and you're coding them at a higher severity and getting more payments from private payers and the government, that's not a very good practice. Okay, I wanted to show you MCare stock price. This paper was covered by Margot Sanger-Katz in the New York Times. It was on the front page. And the day that it was on the front page, MCare stock price fell quite a lot. You can see that first black arrow. The second black arrow, I actually mislabeled it. The congressional hearings started happening after our paper came out. But the day of that enormous drop, the second enormous drop, was the day that MCare released some of its financials and made public the proportion of its business that was the out-of-network billing. I think people had not realized to what extent the firm's business model was an out-of-network billing model, and that was news to the market, and when that came out, their stock price fell by quite a bit. Okay, so then what happens? We're going to come back to the politics at the very end, but I'm going to speed forward because we just have a few minutes. So the one thing I want to touch on is the fact that the hospital is not blameless here, that the financial payment from the emergency department to the hospital is part of this whole procedure because the hospital is suffering because its patients are having this bad experience in the ED by getting these bills afterwards. So there's three ways that physicians, the ED firm, MCare, let's say, could compensate the hospital. They could just give them money. Okay. That might take the form of a reduction in the subsidy. Maybe the hospital was subsidizing the ED and they subsidize it less. Okay. The physicians could alternatively practice in a way that benefits the hospital in terms of revenue, like admitting more patients than they did before, or the hospital and MCare could actually make a joint venture and run the emergency department together. Okay. And those are ways in which the MCare can share the profits from this strategy with the hospital. We find anecdotal evidence of all of them. There's a funny little clip on the internet, which I will not pay you, which is about a meeting, which captures a real hospital board meeting where they talk about having to pay MCare if they want them to go in-network. We find evidence, as I showed you with the CPT codes and so forth, that the physicians are in fact practicing in a way that benefits the hospital. There are greater admissions to the hospital and more severity and more imaging. Okay, so this gives the hospital millions of dollars more revenue. And let me show you what that looks like. So the total payment to the hospital goes up by $220. Okay, the facility charge goes up after MCare entry, but the payment goes up. So this is not the physician's payment, this is the hospital's payment. Okay? So total payment goes up, imaging goes up, and admission to the hospital goes up. And that's not from any, that's from the change in the name of the party running the emergency department. Exit, I'm going to skip over. Okay, so we have the clip from the internet on the ED subsidies. We have our own evidence on physicians practicing in a way that benefits the hospital. We know from anecdotal evidence, again, that there are these joint ventures. HCA, for example, a for-profit hospital, established a joint venture with MCare and ran their own emergency departments in this way. Okay, and So we don't really know what the payoff to the hospital is, but this is the kind of evidence that we have, and you can see that there's definitely a positive payoff. So you could make a guess and say that's something like $2 million for a representative hospital, and a representative hospital is making about $12 million in profits at this time, so that's a significant chunk. Okay, let me tell you about New York. New York established a surprise billing law during our time period. We can study it. There are two things that these laws typically do. They protect the patient so that she is only paying in-network rates. And then the question is, what do you do about the missing price? How much should the insurer, in fact, pay the doctor? Okay, let me show you what that looks like. First of all, out-of-network prevalence falls. In-network physician payments fall, as well as out-of-network. Well, there aren't so many out-of-network physicians, but 2 points to be made. The prevalence falls, and then remember I told you how the bargaining, if I can threaten, if you don't pay me a high price, to go out-of-network and be inside your ED and get all your patients, okay? If I can threaten that credibly, you have to pay me a large amount of money. In New York, once you pass this law, a doctor can't threaten to do that anymore. If you don't pay me a high price, I can't get a high price in your emergency department because the state has made it illegal. What that does is it lowers in-network physician payments. So you may think that this is only a problem that affects the out-of-network doctors, but it in fact affected all in-network prices as well, because every one of those doctors could threaten to go out-of-network to get a higher price. And instead of doing it, they settled to stay in for a higher rate. And you see that here when New York bans out-of-network billing, you see that in-network physician prices fall. Okay? So that's a really important finding, and there's the graph of the prevalence. The neighbor states are in gray, and New York is in blue. So they successfully dropped the prevalence of out-of-network billing, and this is just the distribution of what that hospitals look like. Okay, in my closing couple of minutes, I'm going to give you policy options for what to do about out-of-network billing. So one is arbitration. Make the doctor and the insurance company go to arbitration. That's what New York did. Another one is to set the price, 150% of Medicare. Let's just have the government choose a price. Okay. The third one is to require the doctor to join the same networks that the hospital in which they practice has joined. Okay. I don't like any of these. Let me explain to you why they're all not good. Arbitration has high transaction costs, and in New York, it actually involved the patient, so that was really bad. If you left the patient out, arbitration is the best of these, but it still has transaction costs. Choosing a price is a bad idea because different states are going to want to do different things. Different hospitals in different states, rural areas might have a shortage of doctors, urban areas not. Some doctors are good, some doctors are not so good. You'd like to be able to have flexibility to pay doctors different amounts according to labor market conditions. Network matching really reduces the bargaining power of the doctor because the insurance company can see that you're in Houston and can see you want to practice in this hospital, and they say, wow, for you to get that job, you have to sign up with me, Cigna. And now I know that you have to sign up with me to get that job, so I'm going to offer you a really low price. And you're going to take it because otherwise you can't practice in the hospital. Okay, so that gives the insurance company a huge amount of bargaining power. So the one I like is that the hospital should simply staff its own ED. And the insurer should pay one payment to the hospital for emergency care, and you would get the crutches and the room and the bandages and the nurse and the doctor all in one package, and then it would be up to the hospital to go out and find doctors. And they would have to pay competitive rates to get those doctors, and when you went to a hospital, you would be in network in every way. The bandages, the nurse, the hospital, and the doctor would all be in network because it's organized by the hospital. So that's what I think we should do. Now, after all of this happened, we got movement in Congress. Both the Senate and the House introduced bills to limit out-of-network billing because nobody thinks this is a good idea, except MCare, okay? And that turns out to be a notable exception. Those bills were trundling along. Zach and I were getting a lot of phone calls. We thought there was going to be a vote. Trump was in favor, okay? Unexpected opportunity to agree. Everybody was, the train was moving, and then the train stopped because the private equity firms that own Team Health and MCare started advertising against the senators and congressmen who had submitted these bills. They were putting out TV ads saying that these were elected representatives who wanted to regulate prices, and they were against doctors. And this, of course, the advertising was under some name like, I can't remember, probably up here, you know, Doctors for Fair Prices or something. And nobody knew where it was coming from, and it took the same reporters at the Times to dig and discover that it was indeed the private equity firms that were behind them. Yeah, Doctor-Patient Unity, that's what they were called. Spent $28 million into ads opposing the legislation without disclosing its staff or its funders. So the New York Times figured this out, went and interviewed the senator who sponsored the legislation, the congresswoman who sponsored the legislation, and they said, we don't know these people. This is an attempt to intimidate us. We object. We're going to go ahead with this law anyway, but nothing has happened. Approaching $30 million over 2 months in direct mail and TV ads. So this is. Sorry, I didn't know this was going to go live. I'm going to move on. Okay, we don't want to see that. Okay, so the mystery, as I said, was solved. It was the private equity firms who don't want to lose this source of profit, right? Being able to surprise bill is very lucrative, and this law is going to take away that money. So they are buying the congressmen and the senators that they need in order to stop the legislation moving forward. And that's where we are right now. It's stalled. No progress. So I think this is just telling you what the paper says. Out-of-network billing is frequent. Private equity firms buying up these staffing companies and making money. Policy could immediately fix the issue, but we have this wave of lobbying. So what I now think about American healthcare, and again, this ties back into Medicare for All, is that I think that the work that my colleagues and I do, trying to think of clever ways to reduce healthcare spending and get better outcomes and make the system more efficient, is all really a complete waste of time. That we're spending 20% of GDP on this, and the reason we are is because the money buys the political power to have that happen. We know perfectly well how to make all of this fixed. It's not that hard to do very sensible things, but nobody is going to do very sensible things because the people making money off of it are going to pay to make sure that we don't do that. So we're not going to lower the percent we spend on healthcare. It's going to keep going up. 19, 20, 21, 22. Texas is a bad state for this. You guys have really terrible spending. So, especially given the amount of uninsured people you have. I don't see anything good happening for a long time until people are so angry that there's pitchforks in the streets. And then what we're going to get is not sensible reform of the kind an economist would like. We're just going to get nationalization of stuff. I do think that Medicare for All is coming. It probably won't come anytime that soon, but when we get to, say, 25% of GDP being spent on healthcare, then eventually we'll have a big tip and we'll just end up with, a national health insurance kind of scheme. So that's all from me. On that cheerful note, I will stop. Does anybody have a question?
Hi, I'm Kurt Walker. I'm an emergency physician for many years, and I also like to look at the big picture issues on a lot of things, because I really started out being an engineer. I would like to ask that you change one way you present. I agree with almost everything you're saying, but it is not emergency physicians who are doing this. It is the contractors. Unfortunately, emergency physicians let these people, these MCares and Team Health, come in and take over, and they take over a contract, and you don't have any choice
Yeah, no, that's fair.
about working for them or not. And you don't have any choice, and you don't see any of this billing stuff. And even though they're using my NPI and,
Right.
to disguise it, but we have even less power. So don't go in and chew on your emergency physician and emergency department.
I should
And
say
would
staffing company every time.
I think
You're
that's
right.
what you should use, is not emergency doctors, because that's not where it starts. However, and I see only one element of hope in all this, is that the existence of parasitic companies like MCare and Team Health, that there's huge benefits and savings because they are doing nothing good and they're taking huge amounts of money. Look at their capitalization, and they are not paying the emergency physicians
That money.
a tiny piece
Clearly
of that.
not.
And
Yeah.
they're just scraping in off the middle because they exist and they could be made to disappear, instantly.
But they can't be made to disappear.
Right.
They
No, they could
lobby
be.
so that we can't disappear them. That's the problem.
That is true.
I agree with you.
And I agree that, we need to fix, election funding and our Congress, but they could go away instantly with
Yes.
Medicare for all or, any kind of reasonable regulation, because it's a crazy thing that exists in emergency medicine, and that's just one place that we could save a huge chunk of money.
Yep.
And
Oh,
take
and there
care
are
of
many.
patients. Yeah,
So
that's one of many, right.
So thank you for that comment. That's correct. We have not gone to try to look, and I don't know if you could, look to see if the income of the physicians in the MCare hospital goes up. I suspect the answer is no, a little, because they're billing more, so it has to go up, but the bulk of the money here is being taken by the staffing company. That it's correct. I should clarify that. We don't have results on doctor income, and I suspect it's not changing very much.
Yeah. Dr. David Hoyer, emergency physician.
2 in a row.
Yeah, well, I want to echo what my colleague just said over there, but one other point that needs to be made that I feel like is missing from this presentation is that the fact that emergency departments are operating under an unfunded federal mandate to see every patient who comes into the ED who may have an emergency. A lot of those people pay nothing. So this whole business, or a lot of this business about, these surprise bills are so big. You can't look at what the insurance company is paying the emergency department for that particular patient. You have to remember that that bill has to cover unpaid bills that from previous patients. So that is an important factor in when you look at emergency department economics.
I agree that the uninsured are a very important part of the economics, but we don't fix the fact that we have uninsured by surprise billing insured people. Okay, that's like 2 wrongs don't make a right. Okay, so if we have uninsured people coming into the ED, we need to have the government paying for them in some way, or we need to have the hospital paying for them in some way. We're going to make some social plan. But I don't like the social plan being an insured person who happens to break her leg gets stuck with an extra high bill when she goes to the ED, and that's the way in which we pay for the uninsured. Okay, that doesn't make any sense. We should pay for the uninsured in some more broad-based, equitable way that's not about the particular people who get in a car accident this week, right?
Hi there. I'm a PhD, not MD, but health policy advocate, and a colleague of mine over there and I were in Dallas the last 2 days with AARP, going over the lobbying, and Texas has made significant changes this last season, which we're
is
staying on
great.
top of. So my question is for large grassroots advocacy organizations like AARP, given the significance of the numbers and everything else, I appreciate the information you're going to get me that I'm going to funnel up to them, but there are any other groups that you're aware of that have the clout that with the information could assist? Because, the older you get, as Gloria Steinem said last night, the more fearless you are, and we're not afraid of private equity.
I think that's marvelous. Actually, on my Twitter feed, because I talk about out-of-network billing, I get the AARP's ad. saying that out-of-network billing is a bad idea. So I appreciate that. The other place I've seen an ad for out-of-network billing is at National Airport in Washington on the escalator. United Healthcare Group has an out-of-network billing is really terrible kind of ad. Those are the only two entities I have observed over the last few years that are trying to bring this to more prominent attention. I think there should be more because the private equity firms, there's only two of them, and they're not that big. The AARP is bigger than them. All the insurers should be talking about this, not just one, and try to get Congress and the Senate to see that there's more dollars that want this to go away than there are dollars that want it to stay.
Hi, Dr. Scott Morton. I'm Marcellus Ruhl. I'm a surgical resident at Duke. Excellent talk. And I had a question. I was hoping you could speculate on some of the reasons why why MCARE may have left hospitals or exited hospitals, and maybe counterbalance what those incentives might be and whether or not those hospitals may have replaced certain aspects of their business model with other ones.
That's a good question. We have not investigated that, so I don't know why they've left. I have one anecdote, which is I'm actually friends with an emergency department physician who left an ED because it was taken over by MCARE and went out to the small hospital near the Los Alamos labs and to run that because they had gotten MCARE in not realizing what was going to happen. Then they got all the out-of-network bills, and what MCARE hadn't realized is that Los Alamos Labs has a lot of really smart people working there, and they figured out the deal and made a fuss and kicked them out. And so my friend came in to run the ED after MCARE had been kicked out. So that was a case of an informed community realizing what the strategy was and choosing not to have that strategy in their local hospital. But we've only got a handful of MCARE exits, and we should go investigate what happened. I don't know the answer to your question, basically.
Hi, my name is ID Boyejo. I'm with BBVA. I'm a healthcare banker. And my question is around the phenomenon of freestanding ER departments. I know your study didn't cover that, but can you share some commentary around that trend?
They're very expensive, so they're out of network also. So they're trying to get people to come to them, and then they bill the insurance company a really high amount of money, is my understanding of the business model. I have not studied that in detail, so I can't really give you an informed answer about that. But the reason that a hospital would want to have an ED, there's uninsured people who come there, but there's also admissions. A lot of admissions come in through the emergency department. So you don't really want a freestanding emergency department. I mean, a lot of the people who arrive are going to go upstairs. So it seems more sensible to have an ED in a hospital.
Yeah, if you check out the Baker Institute webpage, we've actually published 4 papers recently on freestanding, so there's a whole issue of policy things very similar to what's going on in the surprise billing area. And so related to that, what happens is slowly the consumers have figured out that freestandings are just not the place to go because you are going to receive a surprise bill. I'm wondering what's happening over time. Do you see patients and any information getting out in terms of people know, oh, I do not want to go to that hospital in an emergency? So how much does information play a role in terms of putting a stop to this?
We have not been able to study that. We don't quite have the right data for that. I'm skeptical that it's going to work very well just because for most of us, luckily, emergencies are rare. So you're not going to the ED very often, nor is anyone in your family going to the ED very often. And then the surprise bill comes after and probably trails on in paperwork for months after that. So tracing back what I eventually pay as a person to the doctor and then associating it to the hospital, I think is just hard, and most people don't have that happen more than once or even once, and so it's going to be difficult to learn. in a way that some other markets might. It might be harder to do this kind of fraud, essentially, in markets where consumers were repeat customers. But here they're really not repeat customers. I wanted to say one thing. There was a gentleman over there who asked about the vertical mergers, the Aetna, CVS, and the Cigna Express Scripts. I worked on the Cigna Express Scripts merger, and just so that you know, I'm not an unbiased person, but I volunteered to work on it because one of the things, while it's true that you're combining those companies and making the corporation larger, what you're doing is you're putting health insurance and pharma insurance into the same entity. When you think about that, it makes a lot of sense. Suppose that there is a drug that costs a lot of money, but it keeps me out of the emergency department, okay, or out of the hospital. If that drug costs $5,000, a freestanding pharmaceutical insurance provider does not want to give that out. That's just a cost to the bottom line, right? That's $5,000 of cost they would rather I didn't incur. If it keeps me out of the hospital and saves the health insurer $20,000, okay, the health insurer would be pretty keen for me to take that drug. If you put the pharma and the health together into one corporation, they can make a decision about the total bottom line, medical and pharma together, rather than making those decisions separately. And we actually have a literature showing in Medicare Advantage that this is what happens, that what Medicare Advantage plans, because they're pharma and health together, do more pushing of medicines that keep you out of the hospital. They have lower copays on the medicines that keep you out of the hospital. It's just a more efficient combination of activities. So that was the reason why I thought that the mergers were actually good, because you would get better control over total cost of care instead of having these silos, the medical silo and the pharma silo.
Thanks. It sounds like bundling risks and the benefits together. It sounds
Yes.
It's smart. It's also similar to what you have on 4 of the bills, of the 6 bills that were mentioned. Which is the closest bill that mentioned the number 4 and the idea of bundling those two things that you just mentioned?
Yep. None of the bills, of course, does what the economist wants, option 4.
What was the closest,
That would
though?
be too hard. They are a combination, some are 1 and some are 2. So there are bills, there's a federal bill that proposes arbitration, and there's a federal bill that proposes setting a price. If you set a price, you just get a funny thing where if the price is going to be 150% of Medicare and that's above the in-network rate, no one's going to go in-network. They're all going to stay out and get the higher government set rate. If the government set rate is below the in-network rate, then the insurer doesn't have any incentive to form a network because they can get it cheaper by going with the government set rate. So the rate setting is just never going to make anybody happy. Arbitration is a little better in my view because you can respond to different demand conditions.
From the senators and congressmen and women who championed the 6 bills, have any of them heard your 3 and 4 proposals?
Oh yeah, I've been on the phone advocating for 4 lots and lots of times.
And they just dismiss
I don't
it?
know. I don't know why it's difficult for
Not
them to
sure.
understand. It seems
Okay.
very intuitive to me. Just staff
thought
the
it was great.
emergency
I understood it,
department,
I think.
and then we all go. What's the problem? I mean, they already hire nurses, hospitalists, other people. I don't see what's so difficult about it. But anyway, it's
No luck.
nobody wants it for
Okay,
whatever
thanks.
reason. All right, no more questions. You were so thorough. Yeah.
Thanks so much. Yeah, I was remarking to Fiona, she was so thorough that everyone understood it completely. Thanks so much for staying with us. It was 4 talkers, 4 speakers, lots of material coming at you very quickly and very, as you can see, very complicated as well, dense material. It will be, the slides will be posted on the website. So you'll be able to access them there, and videos, if you want to mention to any of your colleagues or friends to have a look at these, those will be posted as well. Fiona, I'm never going to invite you again. I'm just kidding. That was an interesting discussion, and we just don't have time to follow up. Maybe we'll follow up, later after I formally close the event. But I wanted to thank also, this event is very easy for me. Once I invite the speakers and we get a date, I basically sit back, and there are this entire team behind me that takes care of everything for you today. So Brenda Laymance here has been terrific in terms of all the logistics of getting the speakers here on time and getting you all well fed and all that. We also, thanks very much to our entire event staff in the back office taking care of details, our audiovisual team back here who makes all this possible. So thanks again, and we hope to see you back in another 2 years.